and welcome to Non-Muscle Invasive Bladder Cancer Experts Discuss the Treatment Options. I'd like to take a minute and thank our sponsors, Genentech, EMD Serrano and Pfizer, AstraZeneca, and Merck for their support. What I'd like to do right now is introduce our speakers, Dr. Trinity Bivalacqua and Dr. Arlene Bivalacqua. Dr. Bivalacqua is the Christian Evanson Professor of Urology and Oncology and the Director of the Urologic Oncology at the James Buchanan Brady Urologic Institute. He was recently named Deputy Director of the Greenberg Bladder Cancer Institute at Johns Hopkins Medical Institute, and we're really happy to have Dr. Bivalacqua with us. Would you like to say hi?
Hi, everybody. Thank you. Welcome.
Great. And then Dr. Arlene Bivalacqua is an Associate Professor in the Department of Genitourinary Medical Oncology, the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. She's a clinical co-leader of the Bladder Specialized Program of Research Excellence, or SPORE, in the Executive Committee there in Houston, Texas. So Arlene, it's really a pleasure to have you with us as well.
Thank you so much for having me.
All right. Well, welcome to the webinar. I'm going to be speaking on non-muscle invasive bladder cancer. There's a lot of ground to cover in a short period of time, but we'll do our best to help educate our patients. We'll start with just some basics about urothelial cancer. As you know, there's approximately 80,000 new cases of bladder cancer diagnosed each year, and unfortunately, over 16,000 deaths. The average age of patients diagnosed with bladder cancer is 73, and men are affected more than women, and we know that one of the major risk factors is smoking. Today, we're going to focus our efforts on non-muscle invasive bladder cancer, and this is what is considered early stage disease. There is a lot of activity and a lot of research that is currently being conducted on non-muscle invasive bladder cancer, and we're learning a lot more about the early stage disease and how we can more appropriately treat it. Today's talk will not focus on muscle invasive bladder cancer or metastatic disease, but the early stage. So the presenting signs and symptoms of bladder cancer, and this is for all stages, is microscopic hematuria or gross hematuria, or more simply stated, when you see red blood in your urine, either underneath the microscope or visually. And this is actually the presenting symptom in 80% of patients. Another common symptom is irritation in the lower urinary tract. And what that means is if you have to go to the bathroom more often or if you have painful urination. This can be a sign of invasive or early stage bladder cancer. It's also a sign of urinary tract infection or kidney stones or even bladder stones. So oftentimes patients, physicians, in particular primary doctors or even urologists, may confuse these symptoms. Symptoms consistent with more advanced disease or pain or blockage of the kidneys. The most common and the gold standard procedure used to diagnose bladder cancer when a patient has these symptoms is by placing a small telescope, is the best way to think about it. It's called a cystoscope, into the bladder. And this is done very easily in the office, and it allows the urologist to be able to visualize any abnormalities in the bladder lining or mucosa. This could be a papillary tumor, or it could be red areas in the bladder, and you may oftentimes hear people talk about these velvety patches or erythematous mucosa. This is where you have raised lesions that are consistent with carcinoma in situ. The most common imaging to diagnose bladder cancer today is a CT scan. Back when I was a resident in training, we used to have IVP conferences every week, and this is called an intravenous pyelogram. This is not the most common way to diagnose it, but today we have wonderful CT scans or MRIs that help us more accurately assess the bladder. As I stated, today we're going to talk about early stage disease or non-muscle invasive bladder cancer. Understand that this is the most common newly diagnosed bladder cancer. 70% of all bladder cancers are diagnosed in early stage disease. The most common is these papillary tumors, as you can see here, 70% of the time. When a patient develops more advanced disease, and when I say advanced, not into the bladder wall, but underneath the mucosa of the bladder, it's called stage 1 or T1, or CIS, or carcinoma in situ. Now, carcinoma in situ is not like carcinoma in situ of the skin, like a basal cell. Carcinoma in situ is actually a high-grade cancer, and we believe that it's actually the precursor lesion or the beginnings of the more advanced cancers or more higher stage cancers such as T1. Recently, the AUA and the Society of Urologic Oncology brought together a number of leaders in bladder cancer to put together guidelines to help urologists manage non-muscle invasive bladder cancer. One of the questions that we received early on was, how do we get rid of and diagnose bladder cancer? Well, the way that we do that is by placing a scope inside the bladder in the operating room and perform a transurethral resection of the bladder tumor. Here's an actual picture of a tumor in the bladder with the red area around the tumor. The urologist puts a scope inside of the bladder, and at the end of the scope is a actually loop that is able to cut and remove the bladder tumors. We're also able to remove all of the tissue down to the muscle in order to accurately stage that, to stage the cancer. Importantly, the urologist is able to tell what the tumor looks like, the location in the bladder, the size, and the number. And this is important when we think about treatment. Additionally, the guidelines now talk about risk stratification, where patients are diagnosed with different risk strata: low risk, intermediate risk, or high risk. Now, risk stratification is put together in order to help us understand which tumors or which type of cancer, early stage cancer, is at the highest risk of progression, which means progressing to muscle invasion. So patients that are diagnosed with a small tumor, less than 3 centimeters, low grade, these patients are considered low risk, which means they are at the lowest risk of progression. Additionally, we have small lesions which are called pun lumps. These are papillary urothelial neoplasms of low malignant potential. These are tumors that are considered cancer, but are very, very indolent and almost benign. If a patient is diagnosed with intermediate risk bladder cancer, these are patients with low-grade tumors that have a recurrence rate that occurs less than 1 year after diagnosis. They may actually be multifocal or greater than 3 centimeters in size. And if you actually have a high-grade tumor, which is small, less than 3 centimeters, this is considered intermediate risk. High-risk patients are patients with high-grade tumors greater than 3 centimeters, T1 or CIS, if they have multiple recurrences or have something called variant histology with lymphovascular invasion. This is when bladder cancer or urothelial cancer is found to have a unusual architecture seen underneath the microscope. This is called variant histology. You may have heard of terms like glandular features, squamous features, or micropapillary. This is which is considered to be a high-risk feature. Now, what we'll talk about later is how do we treat these different risk stratifications, so that more to come about that. Now, theoretically and historically, low-grade tumors were treated with just removal, with a TURBT, or a transurethral resection. And if they develop recurrences, then we started to recommend treatment. And high-grade lesions, which are the majority of tumors that are found, are treated with intravesical immunotherapy, or BCG, which we'll talk about in detail. Now, the typical monitoring of a patient who is diagnosed with bladder cancer after the tumors were removed was to perform a cystoscopy in the clinic every 3 months for 2 years, and then, if there is no evidence of recurrence, they then had a cystoscopy every 6 months for 2 years. If no recurrence, then a cystoscopy yearly or annually indefinitely. Additionally, we oftentimes will obtain a CT scan every year in order to look for any cancer that may develop in the linings of the kidney or ureter. We always obtain cytology to help us see any microscopic cancer cells. And there's a lot of work being done on molecular cytology, which we will not talk about in detail today. Well, the AUA Guidelines Committee came up with a revised protocol for surveillance, and this is now risk-adjusted follow-up strategies. So if a patient has low-risk disease and they have no evidence of any cancer in their bladder 3 months after the tumor has been removed, the recommendations now are to increase the cystoscopies to 6 to 9 months for 1 year, and then, annually, and then stretch this out to no cystoscopies after 5 years if there's no evidence of recurrence. However, I will say that this is a shared decision-making with the patient and the clinician. So it's a decision that the clinician and the patient have to make together. In my practice, I typically will stretch patients out to yearly after 2 years of having no evidence of disease. Now, if you have intermediate risk disease, once again, this is the majority of these patients have low-grade papillary tumors. If the first surveillance cystoscopy is negative, and that's done 3 months after the tumor is removed, then the clinician should perform subsequent cystoscopies every 3 to 6 months for 2 years, and then every 6 to 12 months for years 3 and 4, and then annually. Now understand that this is something that is done, once again, with the patient, and it's a conversation that you have with your physician. But these guidelines were put together in order to have a risk-adjusted surveillance protocol, because all bladder cancer patients know it is inconvenient to come into the clinic every 3 months for the first 2 years and every 6 months for 2 years after that. And also there's the concern for infection, or also the burden, the economic burden on our society. Now, if you have high-risk disease, this is something where the protocol still stays the same, which is every 3 to 4 months for 2 years, every 6 months for the next 2 years, and then yearly thereafter. Now, in patients with high-risk non-muscle invasive bladder cancer, these are patients with high-grade Ta tumors or patients with T1 disease. It is our recommendation that you have a repeat transurethral resection of the primary tumor site 4 to 6 weeks after your initial TURBT. So if you have a patient with, if you are a patient with a high-grade Ta tumor, we recommend that your physician consider performing a TURBT 4 to 6 weeks later. I will tell you, in my clinical practice, I almost 100% of the time will perform a restaging exam in patients with high-grade Ta tumors. In patients with T1 disease, we do recommend that each physician should perform a TURBT 4 to 6 weeks later in order to accurately assess the stage of the tumor and obtain the deep muscle of the bladder to accurately stage T1 versus T2 disease. Now, why is this important? This is important because at the time of a restaging exam, 30 to 50% of the time, residual tumor can be found. So if you have high risk or high grade disease and a restaging exam is performed 4 to 6 weeks later, anywhere between 30 to 50% of patients will have additional disease found. And we may find up to 20% of patients, especially those with T1 disease, will be upstaged or have a reclassification to a higher stage cancer, which is T2 disease. Additionally, This is important for intravesical therapy because we know that BCG and other forms of chemotherapy are most effective when the bladder has no evidence of cancer. If you look at patients with just T1 disease, the residual tumor is found at the restaging exam almost 80% of the time. And as I stated, approximately 20% can be upstaged to T2 disease. Additionally, we recommend that all patients have their pathology re-reviewed. So if you're coming to Johns Hopkins or MD Anderson, we require that all of our patients have a re-review of their pathology in order to confirm the diagnosis, both the stage and grade of the cancer. Now, the predictors of progression to muscle invasion are grade, which is low grade or high grade, the presence of carcinoma in situ, and the extent of laminar propria invasion, as well as lymphovascular invasion. So this is what we as urologists are using in order to counsel patients as to what is their best treatment options, which may be intravesical BCG or could even be early cystectomy in patients with very high volume disease. The AUA also recommends that patients that have suspected low or intermediate risk bladder cancer receive a single postoperative installation of chemotherapy, in particular mitomycin C, within 24 hours after your TURBT. This is done in order to reduce recurrence. There has been numerous studies that show that patients with low grade, particularly papillary disease, if you receive a single installation of mitomycin C within 24 hours, you can reduce recurrence. The problem is that after a TURBT, if the bladder is thin or if there is concern for bleeding, this form of chemotherapy cannot be administered due to potential risk of side effects. Now, if we go back to our risk stratification, we see that we recommend in all patients with intermediate or high-risk disease that you receive an induction course of BCG. So what is BCG? It is an attenuated mycobacterium developed as a vaccine for TB. And in the early 70s, it was found to have anti-tumor activity against several cancers, including urothelial cancer. It is given 4 to 6 weeks after your transurethral resection of the bladder tumor, and BCG was the very first immunotherapy administered in urology. So we've been using this now since the early 70s, for over 40 years. Now, the protocol for BCG is very important. If you were to receive BCG and have a response, we recommend that all patients undergo maintenance therapy, which was established by Dr. Lamb in the SWOG 8507 clinical trial, in which 3 weekly installations of BCG were administered 3, 6 months after you finish BCG, and every 6 months for 3 years. What I always tell patients is that less than 20% of patients can actually get to 3-year regimen due to irritation, particularly between 2 and 3 years in the bladder. And what this study and what the SWOG study showed is that if you receive maintenance, you had less recurrence over the 3-year period. Now, in 2005, we actually were asked by the FDA to define BCG more clearly in order for us to guide clinical trials. So the new term for BCG, for patients that do not respond to BCG, is BCG unresponsive disease. That's when a patient has a high-grade recurrence within 6 months after their last BCG exposure, which would be induction BCG as well as maintenance. And the reason why we had to define this is because these are the patients that are at the highest risk of progression to muscle invasion. And additional BCG is not feasible. And these are patients that can go into what's called single-arm clinical trials. BCG relapsing is now considered patients that have a temporary response to BCG and then after 6 months recur. Agents that were used in the past for this were gemcitabine with only 10-month recurrence-free survival, 12 months recurrence-free survival of 10%. Valrubicin or Valstar, which is an FDA-approved agent for CIS that has failed BCG, only had a recurrence-free survival of 10% at 1 year. Recently, a combination of gemcitabine and docetaxel seems to have more activity in this space with Michael Donnell's group and Steinberg et al. Reported a 21% recurrence-free survival at 12 months. And we recently showed in our series at Hopkins that we can actually, that we have similar outcomes in this disease space. Currently, there is a phase 3 trial using a gene therapy called Instilodrin. This is a phase 3 trial looking in patients that are BCG unresponsive, that we are trying to preserve their bladder, in which an adenoviral vector overexpresses the gene of the cytokine interferon alpha. This is administered into the bladder, and in a phase 2 trial, patients that were BCG unresponsive had a 12-month recurrence-free survival of 35%. Now, this is the best response we've seen in patients that are that do not respond to BCG. And in this study, there was only 40 patients, and there were a number of different patients with papillary disease and CIS. Due to this very impressive response to the gene therapy using interferon, the SUO-CTC has conducted a phase 3 trial in which we are studying this in more patients. We're all aware of the resurgence of immunotherapy in which checkpoint molecule antibody-based inhibitors are being used to turn on the immune system to fight off cancer cells. And currently, in BCG unresponsive disease, we have 2 trials that are currently ongoing using Pembro, which is a PD-1 antibody-based inhibitor, and atezolizumab, which is a PD-L1. This is new. We're now using immunotherapy in early stage disease, and these trials are just started in enrolling patients. The last trial that I'll mention very briefly is a trial in which Dr. Svitek out of SWOG is using BCG priming, in which he is giving BCG intradermally in order to see if we can have the immune system prime BCG to have a better response. So as you can see, there is a lot of activity in non-muscle invasive bladder cancer as it relates to clinical trials. And this is in BCG unresponsive disease and now in BCG naive patients in order to actually augment and improve BCG's response. Lastly, I'll talk about enhanced cystoscopy, which is also now in the guidelines. In patients that have non-muscle invasive bladder cancer, a clinician should offer blue light cystoscopy. It's called CysView at the time of TURBT, in order to increase detection and decrease recurrence, as well as patients can also consider using narrowband imaging, which is another form of enhanced cystoscopy in order to increase detection and decrease recurrence. Fluorescent cystoscopy, or CysView, or blue light cystoscopy, is a diagnostic tool that allows urologists to see tumors more efficiently. A catheter is placed in the bladder prior to the TURBT. CysView is placed, and this is an agent that preferentially binds to malignant cells. So at the time of cystoscopy, under blue light, you can more accurately see the cancer. And these are just examples of how you can see a papillary tumor here, which is seen with blue light, but where you don't see these other papillary tumors or satellite lesions are adjacent to this, and the blue light cystoscopy helps us identify tumor. This has been shown in multiple trials to more efficiently detect TA and T1 tumors, which has been shown to reduce recurrence.